Bismillahirrahmanirrahim. Assalamu alaikum. Dear students, till now you studied diseases. From today, you will study human beings who have diseases. Clinical medicine will test not only your memory but your character, patience, and empathy. Mistakes will happen, confusion will come, but every sincere effort will shape you into a better doctor. Remember, a good doctor is not the one who knows everything, but the one who cares deeply. Bismillah ar-Rahman ar-Rahim. From books to bedside, what really changes in clinical medicine? Dear students, welcome to third year MBBS and welcome to clinical medicine. Today, you are not just starting a new subject, you are entering a new way of thinking, a new way of learning, and a new way of seeing medicine. Up till now, medicine for you existed mainly in textbooks, lecture slides, MCQs, and Viva questions. From today onwards, medicine will start existing in hospital wards, outpatient departments, emergency rooms, and most importantly, in real human beings. This lecture is about understanding what actually changes when you move from books to bedside, so that you don't feel lost, frustrated, or discouraged in the coming months. So the first part of my lecture, the biggest shift from subjects to patients. In preclinical and paraclinical classes, you studied subjects, anatomy, physiology, biochemistry, pathology, pharmacology. Each subject had clear boundaries, defined syllabi, right or wrong answers. Clinical medicine is different. Here, the unit of learning is not a subject. The unit of learning is a patient. A single patient may have anatomy, physiology, pathology, pharmacology, psychology, and social issues, all at the same time. Real patients do not come saying, "Sir, I'm a case of cardiovascular system." They come saying, "डॉक्टर साहब, मुझे सांस का मसला है, थोड़ा सा चलने पर मेरी सांस खराब हो जाती है." Your job is to connect knowledge, not recall isolated facts. That is why many brilliant students initially struggle in wards, not because they are weak, but because the rules of the game have changed. The second part of my today's lecture is there is no single correct answer anymore. Remember, in clinical medicine, there is no single correct answer anymore. In textbooks, questions are clean and tidy. In wards, patients are messy, incomplete, and confusing. A patient may forget timelines, exaggerate symptoms, hide important history, have multiple diseases. You will often hear seniors say, clinical medicine is about probabilities, not certainties. In third year, you are not expected to give final diagnosis. You are expected to think logically, ask relevant questions, examine properly, and present your thoughts honestly. Saying, "I do not know, but I think it could be," is far better than pretending confidence. Remember this early. Good clinicians are not those who are always right. They are those who are always thoughtful. Remember, in clinical medicine, 2 plus 2 is not always 4. At times, it may be 3 or even 5. The third part of my lecture is history is more powerful than investigations. Let me say something very clearly, very early. If you listen carefully, the patient will often tell you the diagnosis. If you listen carefully, the patient will often tell you the diagnosis. Modern medicine has CT scans, MRIs, and labs, but none of them can replace a good history. None of them can replace a good history. As a third-year student, you are not expected to interpret complex scans, but you are expected to listen properly. You are expected to listen properly. Many students rush to examination or investigations because they feel awkward talking, they fear asking wrong questions, they fear asking wrong questions. Clinical confidence begins with conversation. Clinical confidence begins with conversation, not equipment. If you learn history taking properly, diagnosis becomes easier. Exams become easier. Confidence grows naturally. This is why a large part of this series will focus on history taking skills. Part 4 of my lecture, seeing patients as humans, not cases. Seeing patients as humans, not cases. One of the biggest dangers in clinical life is emotional distancing. I repeat, one of the biggest dangers in clinical life is emotional distancing. One of the biggest dangers in clinical life is emotional distancing. You will hear terms like bed number 12, that liver case, the MI patient. But remember, that case is someone's father. That bed holds someone's mother. That patient has fears, family, and responsibilities. Clinical medicine teaches knowledge, but it also tests character. Clinical medicine teaches knowledge, but it also tests character. Simple things matter. Greeting the patient, asking permission before examination, thanking them after history. These small acts build trust, and trust improves outcomes more than we realize. Fifth part of my lecture is what is expected from you in third year. What is expected from you in third year? Let me remove some unnecessary pressure. As a third year student, you are not expected to be a doctor yet. As a third year student, you are not expected to be a doctor yet. You are expected to be punctual, be respectful, be curious, be honest about what you do not know. Be honest about what you do not know. You are not expected to know all diagnoses, perform procedures independently, impress everyone. You are not expected to know all diagnoses, perform procedures independently, and impress everyone. Your role is that of a learner at the bedside. Your role is that of a learner at the bedside. If you master history taking, basic examination, and logical thinking, you are already doing very well. If you master history taking, basic examination, and logical thinking, you are already doing very well. The sixth part of my lecture is common early mistakes students make. What are the common early mistakes students make? Let me warn you about a few common mistakes. Trying to look smart instead of trying to learn. This is the most common mistake of third year medical students. Trying to look smart instead of trying to learn. Second mistake, memorizing cases instead of understanding them. Memorizing cases instead of understanding them. The third mistake, avoiding patients because of fear. Avoiding patients because of fear. And the fourth mistake, comparing yourself with others constantly. Compare yourself with others constantly. The fifth mistake, the common one, thinking clinical medicine is about showing knowledge. Thinking clinical medicine is about showing knowledge. Clinical medicine rewards humility, consistency, patience, not loud confidence. Clinical medicine rewards humility, consistency, patience, not loud confidence. The seventh part is that about a reassuring truth. Every clinician you admire today was once nervous, once confused, and once afraid of being wrong. Every clinician you admire today was once nervous, once confused, and once afraid of being wrong. No one starts clinical medicine feeling ready. Feeling uncomfortable in wards is normal. Feeling uncomfortable in wards is normal. Feeling slow is normal. Feeling slow is normal. Feeling lost initially is normal. Feeling lost initially is normal. What matters is, are you showing up? Are you listening? Are you improving bit by bit? Are you improving bit by bit? If yes, you are on the right path. So, the closing of my today's talk with you, clinical medicine is not learned in 1 year. Remember, clinical medicine is not learned in 1 year. It is learned patient by patient, mistake by mistake, day by day. This lecture series is meant to simplify your transition, reduce fear, and build strong foundations. So the final words of my today's lecture with you. In the next lecture, we will talk about the identity of a doctor, professionalism, and responsibility. Until then, remember one sentence. Medicine begins with listening, not prescribing. Medicine begins with listening, not prescribing. Thank you. And welcome to the wards. See you in the next lecture. Khuda Hafiz.